Hello and good evening. You're all very welcome. Those of you who've joined us tonight in SIMS for the webinar on PCOS. Thanks for taking the time out of your evening to be with us. So what we're going to do first of all, over the course of the next 40 minutes, half an hour, 40 minutes or so, is we're going to be talking about PCOS. We're going to talk a little bit about myself and talk a little bit about SIMS. We're going to talk about what is PCOS and why does it occur. A little bit about how to identify the symptoms and the problems that are caused and associated with PCOS, some of the tests that we use here and that are used elsewhere, and then finally we'll talk a bit about treatments. We'll break that down into various categories for you. Over the course of the evening, please feel free to write in any questions that you have, and we'll get to them at the end of the chat, and we'll try to get through all of them. But please feel free. There's no questions that are stupid questions. If you want to ask something, please just do. Okay, well, first, I suppose a little bit about me. My name is John Kennedy, Dr. John Kennedy. I've qualified in 2000, so I've been practicing as a doctor since then. I've been working in obstetrics and gynecology for the last 15 years, and so I've seen really considerable change, especially in this field, in the field of fertility, in the field of gynecology, and indeed with regard to PCOS. And we'll talk a bit about that, how things have changed. For the last 2 years, just over 2 years in fact now, I've been working in SIMS. Who are we? We're the largest fertility clinic in Ireland. We probably treat more women than anybody else. We're responsible for thousands of pregnancies at this point. And many of the women and the couples that we would have coming into us would have a history in some degree of PCOS or Polycystic Ovarian syndrome. So, well, I suppose the first thing to say, what is PCOS? And I put PCOS/PCOD here because it used to be called Polycystic Ovarian Disease, then it became Polycystic Ovarian Syndrome. There's going to be a lot of uncertainty. I'm going to transmit a lot of uncertainty to you in this talk because I don't know the answers to all the questions that I'll be asking, and indeed we don't know. Nobody knows the answers to all these questions, but there are working theories about what causes and what it is. Back when I was in college, and we're going back a bit, in order to have PCOS, in order to be told you had Polycystic Ovarian Syndrome, this is what you needed. There was a classical definition of it. You could only be said to have Polycystic Ovarian Syndrome if you had all of the above here. You had to have everything. You had to have amenorrhea, that is to say a total lack of periods, or very, very few periods. You had to be have hirsutism, or extrafacial hair growth, or hair growth on your arm. You had to have poor skin or acne. You had to have enlarged ovaries on both sides on an ultrasound scan with typical kind of PCOS appearances. You had to have disordered blood tests as well. You had to have disordered luteinizing hormone and follicle stimulating hormone. You had to have raised male sex hormones, testosterone and androgen, and you had to have a low SHBG. That's a sex hormone binding globulin. If you had some of these and you didn't have others, then you were told you didn't have PCOS. Now, we know now that that's just grossly incorrect. We know that PCOS is a spectrum and not a diagnosis. It's called a heterogeneous syndrome. That it's very possible to have some of these things, but not all of them. Back in the day, if a woman came in and she had A and B, but she didn't have C, she'd be told that she didn't have PCOS. And that's a misconception that's still persisting in certain places today, when we regularly see women come in and say, oh, my doctor told me I didn't have PCOS, or my doctor told me I had PCOS, and they regard it as being a label. Back when the classical definition was all that we had, it could be said that maybe 2% of the population had PCOS. Now we know that 40% of all women have some degree of Polycystic Ovarian Syndrome. Excuse me. Now, anything that affects 40% of the population cannot be called a disease. It can barely be called a syndrome, to be quite honest. But what we used to think of as PCOS is probably an aggregate of 3 or 4 different conditions which are related. So we tend to lump everything together, and only now we're really starting to tease it out and look at it more in terms of how it's affecting the woman, and trying to define treatments to looking after the specific ailments that affect her, rather than giving her a diagnosis and just moving on. So, why does it happen? Well, the short answer is we don't know. There are working theories for this. There's lots and lots of working theories for polycystic ovarian syndrome, but all they are theories. But there are lots of working theories. We know that there are genetic links with regard to PCOS. That there are family links. That if everybody in your family has a history of PCOS, then chances are you do as well. We don't have specific genetic markers. There are some vague genetic markers that may be linked with PCOS, but we aren't quite sure. But there's definitely some kind of genetic or familial link with PCOS. The third, or the big working theory, is the two-cell, two-gonadotropin theory of ovarian steroidogenesis. Now that's a mouthful for me to say, and it's even more of a mouthful for you guys to understand. So I'm going to try to talk you through this pretty simply and keep things nice and simple. Now, there are two main cells in the ovary. There's theca cells, and you can see them on the right of your screen, and there's granulosa cells, and you can see them on the left of the screen. They're in the circles. And these cells are acted on by the two different hormones that are produced by your head, in the hypothalamus and the pituitary. There's FSH, follicle stimulating hormone, and LH, luteinizing hormone. Now, luteinizing hormone acts on the theca cells, and it encourages you to convert cholesterol into androgens. And androgens are the male sex steroids. That's your testosterone, your androstenedione. Then FSH acts on these hormones, right, a process called aromatization, and converts the androgens to the estrogens. With that surge in estrogen is what causes ovulation on a monthly basis. What we think happens in some cases, or in the severe cases of PCOS, is that there's a failure of the FSH, there's a failure of the aromatization. So you get excessive amounts of LH, so you get excessive amounts of the androgen hormones produced, and a reduction in the aromatization. So those androgens are then not converted into estrogen. So that can leave you with a low estrogen and a high testosterone. And that can cause the symptoms associated with polycystic ovarian syndrome. The other working theory on why this happens is hyperinsulinemia, that high insulin levels or high insulin resistance can contribute to it. And we know that when you hit puberty, your insulin ramps up. We know that if you're overweight or obese, your insulin ramps up, and you can have difficulty. You can have difficulty then maintaining your estrogen levels, and you will have higher levels of testosterone. This all kind of makes a bit of theoretical sense, and it seems to add up, but it certainly doesn't account for a large number of patients who have certain elements of PCOS, like a high luteinizing hormone, a low follicle stimulating hormone, or high testosterone, and people who don't, people who have clearly some degree of PCOS, but have none of these other markers. So there are definitely other mechanisms at work that we don't understand. So, okay. So, moving on a little bit, the symptoms and the problems that we get associated with PCOS. Well, the first two we've spoken about a little bit, oligomenorrhea and amenorrhea. Now, what is oligomenorrhea? Oligomenorrhea is defined as having a low number of periods, long gaps between periods, maybe only 3 or 4 periods a year, although typically it can just oftentimes result in women having longer cycles. So instead of having a standard 28-day cycle, your periods might be 32 or 35 or 40, 45 days apart. The next thing that you tend to see is extra hair growth, hirsutism and acne, and that's as a result of having a high amount of testosterone in your system. What you get after that, again in more severe cases, is obesity or hyperinsulinemia, and that can lead to diabetes. People with PCOS are at increased risk of diabetes, and we know this to be true. Now, that's a little bit of a disingenuous statement as well, because frankly, at this point in this country and in the developed world, we're all at increased risk of diabetes because of the nature of diets and supplementation and high fructose corn syrup and all these other unhealthy things that are part of most people's diets. But certainly that risk does seem to be greater again in people with polycystic ovarian syndrome, having high insulin resistance. And then one of the last things is osteoporosis and osteopenia, brittle bones. If you are at the more severe end of the spectrum with regard to PCOS, your estrogen can be low, and women we know need estrogen. Estrogen maintains healthy bone growth and development. It also maintains good cardiovascular health. So without that, you get a slight dip in bone strength, and as a result, as you get older, tend not to be happen when you're younger, but as you get older, you are exposed to an increased risk of fractures, vertebral fractures, hip fractures, and the like. So it's something to be watched for. But of course, the big problem, and one we're probably going to spend a little bit more time talking about than anything else, is infertility and subfertility. Really, for the most part, PCOS, aside from not giving you periods, isn't a huge problem for most women who have it, but it's when you try for a family that it really starts to rear its head. And how does it do that? Well, in the ways that we already mentioned. If you're not getting regular cycles, if you're not ovulating regularly, then you're going to have difficulty conceiving. And also we know, and again, this is one of those things where it doesn't seem to affect all people with PCOS, which means that PCOS is actually a number of different conditions, but we know that it's in a cohort, in a certain number of people with PCOS, that egg quality can be severely affected as well. Egg numbers, not so much. There's generally plenty of eggs there. We're going to talk about that too, but the egg quality can take a knock, and it is something to be aware of. So if you believe that you have some of the symptoms or some of the things there sound familiar, and you're wondering, my God, maybe PCOS is something I have. How do I tell this? Well, you go and you talk to a doctor, and you probably get a number of tests. Now, it depends why you go into the doctor, what they'll do for you. If you're going and saying, I'm just worried I have PCOS, the first question you're going to be asked is, are you thinking about having children? Are you starting a family? And if the answer is no, then you'll probably get a raft of tests and some treatments outlined for you. Generally, the testing starts with blood tests, and these 4 or 5 blood tests that I have here would be at the core of what is done in most primary centres to test for PCOS. FSH and LH. Well, as I said earlier, your FSH is your follicle stimulating hormone, your LH is your luteinizing hormone. These are hormones that are produced in the hypothalamus and delivered to the ovaries to stimulate the ovaries to do what they should do, develop follicles and mature follicles. If you have PCOS, generally speaking, your LH is higher than your FSH, but not always. Then you can check the male sex hormones, testosterone and androstenedione, and see if they are elevated. The other big one you would check is a thing called SHBG, sex hormone binding globulin. Sex hormone binding globulin is a hormone that women have which sits around in the body and mops up testosterone and androstenedione. And if it's low, it means that you're free, or you're active, biologically active testosterone goes up and can cause the hirsutism, can cause the acne, and can cause weight gain. The other thing you might do is check the person's insulin. All right? More and more, just again to see are they at risk of diabetes. More and more then GPs will check DHEA, which is another sex steroid, to see if it's elevated, which it can be in about 40% of the time in people with PCOS. They'll check your cholesterol because of the slightly increased risk of cardiovascular disease to make sure that's not a concern. And sometimes they'll do a fasting glucose. And then that ties in again with the insulin to make sure that you're not actively diabetic or at risk of diabetes. And that's all well and good, but it's not the core blood test that we would do here. The core blood test that we do here for people with, well, for everybody really who walks through our door, and for people especially that we suspect who have PCOS, is called AMH. This is anti-Müllerian hormone. This is a protein hormone that's produced by the ovaries. Eggs aren't simple. We don't make eggs. We start off our life with our complement of eggs, and as we get older, we use them up. The average age of the average age that a woman runs out of eggs at is about 44 years old. Your AMH is a test of that ovarian reserve, essentially how many apples you have left in the barrel. We know what your AMH should be based on your age. There's good data on this, so we have good reference ranges, and you can see that on the chart here. What we also know is that in people with PCOS, because they're recruiting follicles, but because there's no FSH to trigger that release of the final maturation, growth, and release of the follicles, that you tend to store them up, is that people with PCOS hold on to their eggs. And so their AMH is traditionally quite high. How high your AMH is for your age is a reasonably good measure of how badly that PCOS may impact on your fertility. And indeed, it tells us a little bit about your risks of problems associated with fertility treatment or problems associated with trying to conceive. So we tend to use AMH here a lot, not just as a marker of whether you might be somewhere on the PCOS spectrum, but indeed how severe you are. So you do the blood tests, and the other test that will traditionally be done is a scan, and not just any scan, a transvaginal ultrasound scan, specifically looking at the ovaries. As I said earlier, with PCOS, the ovaries tend to hold on to follicles, so you get lots of multiple small follicles. And the classic appearance is what you see here. It's called this string of pearls appearance, where you got lots of little follicles on the outside of the ovary. And this picture here is a picture of the ovary. This is the ovary here. These are all the little follicles which contain immature eggs, which aren't going to be released. And then inside are the cells that are producing the male sex hormones, which aren't being converted to female sex hormones, which aren't being seen, so the woman is not adequately estrogized. And it is this hormone production factory in here which is not working correctly. And that's relevant because of one of the treatments we're going to talk about in a little bit. So that's kind of what it is. It's a disorder characterized maybe by blood test anomalies. It's characterized maybe by appearances on scan, or maybe by some symptoms like not getting regular periods or having hair growth, or in certain extreme cases, vocal changes. But it's entirely possible of one, two, or many of these symptoms. So you get the diagnosis, you do the test, you're somewhere on the spectrum, and you're going to talk about treatment. So what should be done for you if you have been given this diagnosis of PCOS? Well, honestly, it depends entirely on what you want to do. The two treatments can be broadly defined into non-fertility treatments and fertility treatments. You tend to manage PCOS while somebody's not trying to get pregnant, and then assist when they are actively trying to conceive. So the non-fertility treatments depends to a certain extent on what the problem is. But usually, if there is a weight issue, somebody is overweight or has a high BMI, it's about weight reduction and lifestyle modification. And we're going to talk about this in the context of fertility treatments as well, because it's also important there. This isn't just for PCOS, it's for general health. And the weight reduction is usually on the basis of a low glycemic index diet, low GI diet, and there aren't too many people out there anymore who don't really know what that is. It's like the diabetes diet. It's essentially avoiding anything that ever tasted good. That's harsh. Usually what you can say to somebody who has PCOS will find it more difficult than somebody who is of an equivalent BMI who doesn't have PCOS to lose weight. If you have PCOS, you have a tendency to hold on to these fat cells, and it is more difficult to lose weight. So you get some sympathy for that. It's much, much harder if you have a certainly more severe PCOS to lose weight, but at the same time, it isn't impossible, and the effort has to be made. And lifestyle modification and triggers and low glycemic index diet is the mainstay of that. And the other problem, if you're not trying for a child and you have PCOS, is that you're not ovulating regularly, you're not getting regular cycles. And as a result, your estrogen can be low, and that can put you at risk of diabetes, that can put you at risk of high insulin, it can put you at risk of cardiovascular disease. So regulating the cycle is important. And the most common way we regulate the cycle is with the combined oral contraceptive pill. And that's why the non-fertility treatments are at such variance with the fertility treatments when it comes to PCOS. Most people with PCOS will go on the pill until they want to have a family. You can use the progesterone-only pill, or you can use progestogens to try to regulate the cycle, but really that's few and far between. You find a pill that suits you, and you will stay on that. But much more relevance, you have PCOS, either you know or you don't know, and you're trying to get pregnant. Either you've been trying to get pregnant, and you haven't had any success, so then this diagnosis rears its head, or you've always suspected this diagnosis might be there, maybe you've got a family history of it, and so it was always anticipated that you might need some extra assistance. So the treatments, the fertility-based treatments for polycystic ovarian syndrome, well, I've got them here: surgical, conservative, and medical. Now, generally, when you're talking about this, you put them the other way around. It's usually conservative, medical, and then followed by surgical at the end. But I want to put surgical at the top because I just want to kind of square it away. Surgical treatment of PCOS is rare, and it should be rare. It used to be done an awful lot more commonly than it is now. It's called ovarian drilling. Now, maybe some people listening have had ovarian drilling done before. I'm not a huge fan of it. Ovarian drilling involves a keyhole or laparoscopic surgery where a small needle is pushed into the ovary, into the middle here. It's not drilling as such. It's pushed into the ovary, and an electrical current is passed through that needle to heat it up, and it essentially burns a little bit of this tissue on the inside of the ovary where the hormone production factory isn't doing what it should. And so it should reduce the severity of the PCOS. It's not a permanent fix. It only lasts about 6 months. But that 6 months might be the 6 months opportunity for a woman or a couple to conceive and have and carry a pregnancy. The problem with surgical drilling, and it is controversial, is that it used to be done on patients who didn't need it. It was done before the full and formal diagnosis was made. And the other problem is that a lot of people weren't doing it properly. That instead of actually passing the needle into the middle, into the cortex of the ovary, they were just puncturing the small follicles on the outside. And all you're doing when you do that is damaging the egg reserve, is damaging the ovaries. So I have seen patients who've gone for ovarian drilling and have reduced their fertility potential as a result of it. So I'm a little bit wary of it. I tend to reserve surgical treatment of PCOS for people who've been through an awful lot already, been through various forms of fertility treatment, we'll talk about some of them later on, and are just not getting any success. We can't get an appropriate response. And for them, maybe, but it's a small number. The conservative treatments for fertility-based PCOS treatment are much the same as non-fertility: weight loss and lifestyle modification. And usually it's easier to convince people who are trying to get pregnant to modify their lifestyle or weight loss. It's a good motivator to try to shed pounds and try to eat healthy and move more and do all of these things. So oftentimes we do see good results in people as they're trying to get pregnant. And certainly not only in terms of becoming pregnant, it makes a pregnancy an awful lot easier and reduces the risk in pregnancy if your weight is down. So if weight is a problem, then I can't really stress enough, getting weight down is very, very beneficial. Medically, well, the medication I'm going to talk about first is something called metformin or glucophage. Some of you may have heard of this before. Metformin started off life as a treatment for type 2 diabetes. It's an oral anti-hypoglycemic, that is to say it treats high blood sugars as an oral medication. All the data, and there have been loads of trials done on this at this stage, show that metformin is really good for PCOS. It can help regulate the cycle, it can reduce the severity of the PCOS, it can reduce the risks associated with certain fertility treatments, and really it aids weight loss. It's a wonder drug from that point of view. The downside is the side effect profile, is that it can cause gastrointestinal upset. Most people on metformin will have some generally quite mild degree of gastrointestinal upset, a bit of nausea or loose stool, which tends to abate over a few weeks. Some people really can't tolerate it at all, though. So it's not for everybody, but it's worth a shot if you have PCOS to go on metformin and have that working away in the background while you're exploring other options, and it can be enormously beneficial. The other thing, when you're trying to get pregnant, and this really is more the purview of the fertility, the general practice fertility clinics, is ovulation induction agents, the most common of which I'm sure many of you have heard of is Clomid. Clomiphene citrate is designed to stimulate the ovaries to produce, to not let those follicles arrest, but to develop them on so they do grow follicles. And you give Clomiphene in conjunction with what's called TSI, or timed sexual intercourse. The idea is you take the Clomiphene, you work out when you're ovulating, either just by dates or temperature monitoring or using an ovulation prediction kit, and then you have timed intercourse. The downside of this is, and it's certainly a downside of a lot of clinics in the public sector that I worked in over the years, is that if you use decent doses of the Clomid, then you run the risk of not recruiting just 1 or 2 follicles, but recruiting 3, 4, or 5 follicles. Those octomom stories and all those stories of people having septuplets and sextuplets and all the rest around the world, that's not from IVF. That is from ovulation induction agents like Clomiphene being used without using scans. So if somebody has a history of PCOS and they're going to be taking something like Clomid, they really need regular scans to make sure it is safe and appropriate for them to try to conceive on any given month, or they do run a risk of having high order multiples, triplets, quads, and things like that, which can be obviously disastrous for the pregnancy and for everybody involved. So it is something you need to be approached with caution. What I saw back in the past, and it's not done so much anymore, which was kind of depressing, is that because a lot of these places didn't have the facility to scan or monitor the women appropriately, is that they would just give them suboptimal doses of Clomid in the first place, which is not accomplishing anything worthwhile at all, because it's not giving them a decent shot at getting pregnant any given month, but it is safer. The other treatments we would talk about doing would be IUI and IVF, intrauterine insemination and in vitro fertilization. So some of you might know what these are, and we'll just talk very briefly about them. IUI is intrauterine insemination. Reasonably good success rates, best natural fertility in the whole world. Any given couple's chance of getting pregnant under ideal circumstances is about 17%. So IUI, if you get it right, is about 23%. You've got a 23% chance of getting pregnant. IUI involves generally giving somebody medications, trying to recruit 1 or maybe 2 follicles, tracking the growth of those follicles over the course of a few weeks, and then when we know that ovulation has happened, because we're giving a trigger injection, we take a small catheter with a washed, prepared bit of sperm in it and put it in at the top of the uterus. This shortens the journey the sperm has to make to get to the egg. It's a cheaper, and I mean that financially, physically, emotionally, and psychologically, it's a cheaper alternative than IVF. It's a little bit less successful and gives you less information. It's reliant on the sperm being of sufficient quality and indeed on the tubes being open. If the tubes aren't open or the sperm isn't good, then it's not going to work. Again, like with timed intercourse, one of the problems with PCOS and IUI is the risk of over-response, that you recruit too many follicles, too many big follicles. And if you do an IUI, you have a high risk of triplets or quads. In those circumstances, because we're aware of it, because we can see it on an ultrasound scan while we're tracking the cycle, we would either recommend cancelling the cycle or doing a small surgical procedure to take some of those follicles away to make it safer. And that can be done quite easily. The next step up is IVF, in vitro fertilization. So what's that? Well, same deal as IUI, you give medications, but in higher dosages. What happens then is you recruit lots of eggs, anywhere between 6 and 20 eggs. These eggs are then taken out from the ovary with a surgical procedure. The eggs and the sperm are combined to allow for fertilization. Those embryos are generated, grown out for a few days in the laboratory here, and then the best 1 or 2 embryos are put back in the uterus. If you only put 1 or 2 embryos back in, you reduce the risk substantially of high order multiples. In fact, if you only put 1 back in at a time, then you've got even a low risk of twins. And you get to see, the advantage of IVF, of course, is that you get to see what kind of embryos and eggs you're producing. So if you are in that cohort of PCOS patients who has a reduced egg quality, then IVF can tell you that at least. And then maybe we can try to do things to target that to really, and then maybe you'd be looking at things like ovarian drilling or something like that sometimes. IVF obviously carries a higher chance of success in a minimum amount of time, and that's all well and good, but it's not easy. With IVF and PCOS, the big concern we have is that these patients, perhaps you, are at high risk of ovarian hyperstimulation. That's where you lose control of the stimulation of the ovaries and you get too many eggs produced and too many follicles produced. And this can cause quite serious medical risks, resulting in hospitalization or needing to come back into the clinic over and over and over again. Sometimes one of the worst things you can do for somebody who's teetering around the edge of hyperstimulation, their ovaries are too big, there's too many follicles, is getting them pregnant. So really with modern techniques, what we can do now is do half of an IVF cycle. Recruit the eggs, take the eggs out, make the embryos and grow them out. But instead of putting them back on day 3 or day 5, you freeze them. You let the woman get better, and then when she's not gone through a whole bunch of follicle-stimulating medications, you do some gentler, milder medication, and you do the embryo transfer then at the end of it. And more, we're seeing that come into the fore, to the point now that if I have somebody coming into the clinic here who's on the more severe end of the spectrum, I will generally say to them, if you're going to go through IVF, anticipate that that's what we're going to do. Anticipate that we're going to be freezing all these embryos, that we're not going to be doing a fresh transfer on this cycle, that we will in fact be doing it at a later time. And that's managing the woman and the couple's expectations a bit more clearly. And we do know, with good evidence, that that the success rates for that are very high as well. So that's kind of the spiel. To summarize, if you're going to take anything away from this, and I hate to transmit uncertainty, but you have to be honest with people, that PCOS used to be one condition, but now it's not. Now PCOS is referring to a whole bunch of different conditions, and really we don't quite know what they all are. So what we tend to do is treat the person in front of us. We tend to assess where they are in terms of how many periods they're getting, in terms of weight management, in terms of their AMH, and in terms of what they need to do in our context, to have a family. The investigations, therefore, vary depending on what the patient wants. In truth, most of the blood tests that I mentioned earlier, we tend not to do here. I tend not to focus over much on FSH and LH testing. I think the scan is very important. It gives an idea of the severity of PCOS. I think the AMH is very important as well. But the others, and testosterone may be relevant, but the others just aren't as important in terms of how we manage it. So, not only do the investigations vary, so does the treatment. The treatment is absolutely tailored to what the woman or the couple want to do. If you don't want to get pregnant, generally it's just about cycle maintenance, and that's usually the pill. And if you're trying to get pregnant, then it's a question of how long you've been trying for, and the other ancillary factors. How old are you? How severe is the PCOS, and what have you tried so far? This is probably the most important thing I'll say. Most people who have a variant of polycystic ovarian syndrome will succeed in having a family. It's not always straightforward. Sometimes it's difficult. There are sometimes risks associated with it, and there's higher risks of all these various treatments being cancelled because the response is either not quite good enough or there's an over-response. So it can take longer and a bit more effort and a bit more time and a bit more commitment to get across the line. But for the most part, most people who have PCOS, who don't have children, who want children, will succeed in having them. And that's that presentation, and thank you very much for your attention. There are a few questions here. The first question I have is, how long should you stay on metformin when you're trying to conceive? Really, while you're trying, you should be on it. There's no upper limit to how long you can be on metformin if you're tolerating it. A lot of people don't tolerate it so well, so it's really a question of what they can put up with. We do recommend, and there is some data, that being on metformin can reduce your risk of miscarriage. So generally, we recommend that you stay on metformin throughout the first trimester of pregnancy to at least 6 weeks and probably about 12 weeks. And the other question is, How do you know what your egg quality is? Well, that's a great question. It's very difficult. To be overly simplistic about it, a good egg is an egg that makes a baby. And that's how you test egg quality, by seeing does it make a baby. In the absence of that kind of facile, overly simplistic answer, that's what IVF is. When you do IVF, you take eggs out, you take sperm out, and you see what kind of embryos these make. If they don't make good embryos, while there might be other factors, while sperm can certainly be a factor, and you need to look at that, most of the heavy lifting is done by the egg. So if the embryo quality is poor, generally it speaks to the egg quality. If the egg quality is poor, then you have to try to manage that. And that's one of the tougher issues to manage with regard to the whole field of IVF, and indeed IVF as it relates to PCOS. There are various medications and supplementations that can be used. Again, metformin, maybe ovarian drilling in certain rare cases, or sometimes it's just a question of trying a different batch of eggs and seeing it. Like I said, most people, not all, but most people with polycystic ovarian syndrome will get success. Now, somebody is currently pregnant, congratulations, will go on Dianet after baby. Plan in December 15 is to start for baby number 2. Could I do TSI as it worked before? Absolutely. The best predictor of future success is previous success. So what worked before will probably work again. Dianet is a specific type of combined oral contraceptive pill, which traditionally got used an awful lot for PCOS. In fact, it was one of the first ones that was really sold as being, you know what, if you have PCOS, you should go on Dianet. We tend not to use it so much anymore because the data that's emerged now is that the other pills work just as well. Dianet was thought to be better at treating hirsutism and acne and those kind of problems associated with PCOS. Now it turns out the other pills are more or less just as good as doing it. So one of the other problems is that Dianet, for all that it's a combined oral contraceptive pill, is not a pill you want to get pregnant on. It can cause birth defects. So if you're going to take Dianet, make sure you take it regularly, make sure you take it consistently as well, or you could potentially run into problems. My LH is currently, this is the next one, pardon me, my LH is consistently double FSH, but testosterone is low. Does high LH lead to increased risk of miscarriage? Excuse me, I don't believe so. I think this is just very illustrative of how variable PCOS can be. So this is somebody who has got a high LH. Now it's not that the classical picture of LH to FSH was it had to be above a 3-to-1 ratio. So if your FSH was 3, you couldn't say the person had PCOS unless their LH was above 9. Now we know that's not the case. I don't think a high LH than FSH might lead to difficulties conceiving. I think the risk of miscarriage with PCOS, it might be very marginally more elevated compared to the background population, but I don't think it's significantly higher. Testosterone being low is also representative of another subtype of PCOS where you do have these altered hormones but low testosterone, and sometimes in those situations you can use DHEA supplementation to increase the testosterone to try to improve egg quality that way. Number 5, I am quite scared by the prospect of going to investigate this. Concerned about being judged for weight. Do you have advice for dealing with this anxiety? That's really tough. Be kind to yourself is what I would say. I don't think, look at me. I don't think any of us really have the right, the moral or ethical right to judge other people. I think it's a terrible thing to stand in judgment over another human being. We see this a lot with people coming through the clinic. Nobody in their right mind wants to walk through the door of an IVF clinic. Everybody's wishes it would happen without it, without recourse to testing, without recourse to treatment. And asking a question is oftentimes scary, and something's not real until you actualize it with investigations. That being said, excuse me. That being said, if you do have these conditions, then things can be done about it. If you feel that you've gone to somebody to investigate this and they are judging you, or they're standing in judgment, or they're just saying, go and lose weight. And I saw this so many times over the years, people walking into a clinic and being told, you have PCOS, you're overweight, go away and lose weight. And it was dismissive and paternalistic and awful, and I hated it. if you're not going to somebody who's supportive, and you're not going to be somebody who's not just telling you this is the problem, go away and eat less, but is actually putting forward proactive measures, be it medical, be it lifestyle, be it behavioral, be it counseling, be it encouraging weight loss programs, then go and talk to somebody else. These people are not helping you. And I would, if you feel you're being judged on your weight, then I would happily recommend that you judge the person who's doing that by seeking an alternative opinion. You have to think of these things in terms of solutions, not problems. You mentioned diet. What are the key things to do? I have PCOS. Was told about a supplement that helps. Okay, I'd be curious about what supplement that is. Diet, behavioral modification, it's weight loss, it's low glycemic index diet, so avoiding high sugars is really the key, because PCOS and high insulins and risk of diabetes are all so tightly linked at this point. So if you do have, if you are looking at diets, then you're looking at low glycemic index diets. But really, I mean, diet and weight loss it's not about crashing your weight. One of the things that can happen with people going on diets is that you crash your weight quickly, and then it tends to creep back up. And the really unfortunate thing is that it creeps up to slightly above the level it was at when you started. And so overall, at a long enough timeline, you see weight go up, which is very unfortunate and very, very demoralizing. You aren't looking, here's my take on it. There's no such thing as a rate of weight loss that is too slow. So long as it's moving down consistently, not moving up, then you're moving in the right direction. How to prevent and manage the risk of ovarian hyperstimulation, of OHSS, ovarian hyperstimulation, during IVF? Well, one of the key things is being aware of it beforehand, is knowing what the risks are. It can blindside you, of course it can. You can always have patients overstimulate when really you didn't anticipate it at all. But by checking the antral follicle count, by looking carefully at the ovaries, by checking the AMH, by going through a careful history with the patient, you can try to predict who's at risk. If somebody has a high risk of PCOS, you will use lower doses of the stimulating hormones, and you will also use specific types of protocol. And usually the protocol that we would use is a short protocol or an antagonist protocol, because this reduces the risk of hyperstimulation, and it allows us to change how we trigger the maturation and release of the eggs towards the end of the cycle. And that allows us to take the eggs out and let everything settle down in a much faster and safer fashion. Usually, that slightly alternative trigger is associated with the freezing of the embryos that I spoke about earlier, that we wouldn't do a fresh transfer. That's one of the main ways we are now managing the risk of ovarian hyperstimulation, certainly in this clinic, and I think generally and internationally. But most of it's about prediction, trying to anticipate the problems. 8 years trying to conceive, while on Clonmel at hospital, didn't scan regularly. That is an old typical story. Just blood tests on day 21. Could it be possible to have missed the fertile window as didn't have a good result? Yes, absolutely is the short answer to that. I have a fundamental problem. I suppose it's where I've come from and where I am now, with the notion of giving Clomid without tracking cycles appropriately. If you're going to take the time and effort to be on Clomid, I think you should have scans. The problem with the day 21, the blood test being talked about here is a day 21 progesterone. And it rises, and if your day 21 progesterone is above 25 or 30, then you probably ovulated that month. But that's closing the door after the horse has bolted. You didn't ovulate on day 21, you probably ovulated on day 14. You don't ovulate 2 weeks after your period. You ovulate 2 weeks before your period. So if you have a long cycle, if your periods are 35 days, generally, not always, but generally, this can happen in PCOS, generally what's happening is that you're ovulating later. So it's 35-day cycle instead of 28, you're ovulating 7 days later. So instead of ovulation on day 14, you're ovulation on day 21. This can have a problem because the eggs are coming out slower and longer, and that can diminish egg quality. And the other problem is, of course, that you've missed your fertile window. The ovulation prediction kits can sometimes help with this, but in my experience, not quite as good as they should be. And so it can be difficult. Excuse me. The best way to predict when you're ovulating is not to do a day 21 progesterone, is to do a scan to see whether the follicle or follicles are big and ripe and above 17 millimeters in size, and then perhaps to use a trigger injection to cause release and maturation of release of that egg, which can allow you to time things more exactly. But that can only be done in the context of scans, not blood tests. Okay, how do you overcome PCOS, underactive thyroid, and DNA fragmentation? Okay, there's three things here. Well, PCOS, we've been talking about. PCOS, it's a hormonal disorder. Thyroid disorders. Thyroid is a gland in your neck which controls your overall metabolism and energy levels. An underactive thyroid with a high TSH, thyroid stimulating hormone, can be associated with implantation failure, and the two sometimes go hand in hand. There's another linkage there which we don't fully understand between PCOS and underactive thyroid. You manage an underactive thyroid by monitoring the thyroid levels appropriately and treating with L-troxin, usually as the medication of choice. DNA fragmentation is something else entirely. This is referring to a sperm test. Sperm are very simple things. They're essentially just like the creatures that produce them. They're simple and sensitive. DNA fragmentation test looks at how fragile or friable or unraveled the sperm is within the DNA is within the sperm. If it's high, that can be associated with failure, and it can be associated with miscarriage. The most common treatments for a high DNA fragmentation test are lifestyle modification. If there's a weight issue, you lose weight, you stop smoking, you reduce caffeine and alcohol right down, and you try to get healthy. The supplements you would tend to use would be vitamin D supplementation. Sometimes high-dose vitamin D can have quite a favorable impact on DNA fragmentation. Antioxidant treatment, vitamin E, vitamin C, zinc, and selenium would be the other vitamins that would be recommended. But usually, if your DNA fragmentation is particularly high, what you might do is ICSI instead of IVF. This is where you take the sperm, instead of leaving the egg, the sperm to fertilize themselves overnight, you inject the sperm directly into the egg. And that reduces the effort the sperm has to make to get in, so it can overcome DNA fragmentation issues. Now, have tried TSI for 12 months, attempted 3 times but overstimulated, as have large cysts. Is it time for IVF? Depends what age you are, I suppose, and depends how frustrated you are. It's certainly possible that you could get success with TSI. The problem with TSI and the problem with IUI, the problem with all the fertility treatments that aren't IVF, is they don't give you any extra information. So what tends to happen, people who go through IVF become very, very disappointed. It's very upsetting. One of the most upsetting things that people often ever go through is a failed IVF cycle. But people who go through TSI or IUI and don't get success, timed intercourse cycles, tend to get frustrated because you feel like you're getting nowhere. You feel like you've not accomplished anything, like you're treading water, like you're only going backwards. So it may be, but I would be interested to see some of the other markers here, what the AMH is, and things like that. And ultimately, if you've been trying for a year, I think it's probably time to step up and consider doing something else, whatever that is at this point. Is an AMH of 2.4 poor for a 38, 39-year-old? What are the chances of conceiving naturally? Well, AMH, as I won't pull the slide back up, as I said, is a measure of ovarian reserve. When you're 38 to 39 years old, a normal AMH range would probably be somewhere between 12 and 35. So an AMH of 2.4 is quite low and does indicate a diminished ovarian reserve. This tells me 2 things. One, it tells me you need to be really proactive about your fertility options. You need to be getting cracking on having children. The other thing that it means is that when and if you went through a cycle of IUI or IVF, that you mightn't get a huge number of eggs. Now, this is the old, it's about quality, not quantity argument. But I think your chances of conceiving naturally aren't as badly hurt with a low AMH as they would be. Maternal age, or the age of the woman trying to conceive, is probably the key thing. I would probably prefer somebody who is younger with a low AMH than somebody older with a higher AMH, if you follow me. So long as you're still ovulating regularly, then you have an okay, depending on how long you've been trying for, chance of conceiving spontaneously. But you do need to be proactive. The problem there is that in a year or two's time, that AMH might be 1 or even less, and then you don't have the option of considering, or your option of considering IVF and things like that is certainly lesser. Diagnosed with PCOS last year, not overweight, have bad acne. Is there anything I can do to clear skin up? The cosmetic things, in terms of the hormonal treatments that I would be familiar with, the pill, and Dianet was always the traditional pill. Now the kicker with that is that you need to be on the Dianet for about 18 months before it has a real tangible benefit on skin, and some people don't want to do that, or they have fertility options or plans. But certainly from a hormonal point of view, I would probably think about Dianet, but you need to be on it quite on it long term. Dianet can be associated with weight gain as well sometimes, so but if that's not an issue, then that's probably what I would be looking at. I have PCOS and a BMI, body mass index greater than 35, that's overweight, can't start IVF yet. Are there fertility treatments I can try while getting weight down? Absolutely. There's the stuff we spoke about. There's time sexual intercourse, and there's IUI treatments, and there's assessments. And I think for people who like this, they feel like, and I know there's clinics out there that won't treat people because their BMI is over 35. They just turn them away at the door, and I think that's disgraceful. It's not about just putting people into a cycle willy-nilly. It's not about just kind of the conveyor belt mentality or anything like that. It's about managing the person in front of you. It's about encouraging, supporting, and helping the person in front of you. So they can certainly explore those options, get their ducks in a row, do the investigations, and use the results as a motivator for helping them get weight down in a supported environment. Is there a higher incidence of gestational diabetes in pregnancy with PCOS? Should have said that earlier in the presentation. Absolutely there is. People with PCOS are at risk of diabetes, so that means they're also at risk of gestational diabetes, so that's just diabetes in pregnancy. So it is something that would be monitored for, and if you've got a history of severe PCOS, then doing a glucose tolerance test or checking for that at around 20 or 28 weeks might be indicated, depending on what your obstetrician says. To this point, the myth that when you're pregnant you're eating for two has been fully shown. A weight gain of more than 15 kilos in pregnancy is associated with poorer outcomes for both mother and baby. So if you do have PCOS and you do get pregnant, it's very, very important to manage your weight and manage your lifestyle appropriately. Do you suggest starting investigations with a GP, or are patients welcome to come directly to SIMS IVF? That's a nice question. You're absolutely welcome to come directly to us. Just because it says IVF on the door doesn't mean that's all we do. Certainly managing people from a timed intercourse point of view, managing people from helping them with weight loss, managing people from lifestyle modification, from testing, just to see how urgent or how proactive they might need to be, I think are absolutely key elements. A lot of the tests, as I said, can be done in the context of primary care, and if you bring them with you when you come in, we won't repeat them. One of the tests that's not done in primary care that needs to be done in the context of a fertility clinic is AMH. And that's a really, really core part of analysing how severe or where you are on the spectrum. So I think that's important. And I think we have one more. Apologies for the cough this evening, folks. Oh, good Lord, I'm hysteria. You mentioned that IUI is a treatment to try with a high BMI, but I've been told by my fertility centre that my BMI has to be under 35 to try IUI. Yes, I can guess, I think, perhaps what fertility centre that is. I don't know about have to be. Recommend. I think where I come from with this is non-paternalistic. I think what's important is to have a realistic and honest conversation with the person in front of you about what their chances of success are, how those chances are affected by their weight, and then they make an informed decision about what they want to do. Nobody is talking about entering into this frivolously or lightly or casually. So it's about talking to you, and then if it's in the context of, well, do you want to go ahead, and these are the chances, and this is what might happen, and you want to proceed, then it's your decision, and you make that decision. I think turning people away because they're, I mean, maybe you have to draw a line somewhere, because they're 1 or 2 or 3 kilos overweight or above the marker, I don't think is fair. So while it's not an absolute, oh sure, come in, come one, come all, approach or anything like that, it's about having at least a conversation with the people around us. If you walk into any antenatal clinic in the country, you'll find that the benches are creaking. You know, most of the women, the majority of the women who attend antenatal clinics now are overweight, because most people are overweight in some way, shape, or form. So to refuse somebody treatment purely on the basis of that, I think is unfair. Yeah. Absolutely. I think we're probably going to wrap it up around now. If anybody has any other questions, then they can please feel free to email me. My email is Dr. John Kennedy. That's drjohnkennedy @sims.ie. If you do drop me a line, I promise you, I will answer you this week. And thank you very much for your time and attention, folks. Take care.